My name is Lauren Hardin, and I am one of the co-chairs of PTAC along with Angelo Sinopoli. Yesterday, we began our day with opening remarks from the CMS Deputy Administrator and CMMI Director, Liz Fowler, and she offered some context on how her work fits into the center's vision. We also had several guest presenters share their ideas on how integrating specialty care and population-based models can help us to move toward a patient-centered healthcare system. Today, we have a great lineup of experts for today's listening session and our physician roundtable discussion. We've worked very hard to include a variety of perspectives throughout the two-day meeting, including the viewpoints of previous PTAC proposal submitters who addressed relevant issues in their proposed models. Later this afternoon, we have a public comment period. As a reminder, public comments will be limited to 3 minutes each. If you have not registered to give an oral public comment but would like to, please email ptacregistration@norc.org. Again, that's ptacregistration@norc.org. Finally, the committee will conclude the day by shaping our comments for the report to the Secretary of HHS that we will issue on this topic. Because we might have some new people online who weren't able to join yesterday, I'd like the committee members to please introduce themselves. Share your name, your organization, and if you would like, you can share a brief word about experience you may have with population-based payment or total cost of care models. I will cue each of you. I'll start. I'm Lauren Hardin, Vice President and Senior Advisor for National Healthcare and Housing Advisors. I've spent the last 20 years leading and innovating in value-based payment models for complex and underserved populations. Angelo.
Thank you, Lauren. Angelo Sinopoli. I'm a pulmonary critical care physician by training. Presently the Chief Network Officer for Upstream, which is a value-based company that supports primary care physicians. Prior to that was the Chief Clinical Officer for Prisma Health, where I developed our clinically integrated network over a number of years to 5,000 physicians, and also was the founder of the Care Coordination Institute, which was an enablement company to support clinically integrated networks. Thank you.
Good morning. I'm Jennifer Weiler. I'm the Chief Quality Officer at UC Health for our metro community. We're one of the largest healthcare systems in the Rocky Mountain area. I'm co-founder of UC Health's Care Innovation Center and a tenured professor of emergency medicine at the University of Colorado School of Medicine. And I was a co-author of an alternative payment model considered by this committee.
Good morning. My name is Josh Lau. I'm an internist and faculty member at the University of Washington, where I also serve as the Enterprise Medical Director for Payment Strategy. I also lead a group that works on evaluation and research related to payment incentives and payment models.
Good morning. Walter Lin. I'm an internist in St. Louis, founder of Generation Clinical Partners. We are a group of medical providers that care for the seriously ill and frail elderly in senior living organizations.
Good morning. I'm Lindsay Botsford. I'm a family physician by training and a market medical director with One Medical in Houston. I work at Iora Primary Care, where we take total cost of care for older adults on Medicare.
Good morning. My name is Jim Walton. I'm a retired general internist and just recently retired as a CEO of a large IPA in Dallas, Texas. Presently working as a consultant advisory role for Medicaid and ACO REACH companies trying to achieve total cost of care reductions.
And we have two members online. Chinny, please go ahead.
Hi there, Chini Puluru. I'm a family physician by trade. I serve to lead clinical operations for the Walmart Health business. I'm the chief clinical executive of the omni-channel care delivery system. Prior to that, I spent about 15 years leading one of the largest medical groups in the country, and particularly doing value-based care transformation across the risk continuum. as well as all things that are care delivery within that group. Thank you.
Thank you, Chinny. Larry, please go ahead.
Good morning, everybody. I'm Dr. Larry Kaczynski. I'm a gastroenterologist by training, and I practiced clinical gastroenterology for 35 years. Currently, I am the founder and chief medical officer of Sonar MD, a value-based care program for patients with digestive diseases, which began as the first PTAC recommended physician-focused payment model back in 2017. We look forward to today. Thank you.
Thank you, Larry. And two of our members couldn't join today, Lee Mills and Jay Feldstein. Both are physician leaders in value-based payment and innovation. So we're excited to dive in today. I want to welcome the experts for our first listening session. We have invited 5 outside experts to present on developing financial incentives in population-based models. You can find their full biographies posted on the ASPE PTAC website along with their slides. After all 5 have presented, our committee members will have plenty of time to ask questions, so start thinking about what you would like to ask. Presenting first, we have Dr. Kevin Bozic, who is a professor and chair of the Department of Surgery and Perioperative Care at Dell Medical School at the University of Texas in Austin. Welcome, and please begin, Kevin.
Well, thank you, and thank you very much for including me. I've always been an admirer of the work of PTAC and have incorporated many of those principles into our practice. I bring the perspective of a practicing orthopedic surgeon, a chair of a large academic department, and the incoming president of the American Academy of Orthopedic Surgeons, although I'm not speaking on behalf of the AAOS today. And have spent most of my career designing, implementing, and evaluating structural changes to the payment and delivery system that incentivize and reward value, and wanted to share a few of the things that we've learned in our experience. First of all, I think sometimes we forget in payment model transformation that the goal of the health system is to produce health, and health care can be part, but it's certainly not all of the solution. And that the changes to the payment system are intended to change behavior of the clinical teams that are responsible for improving the health of patients. But we've also learned along the way that it can be a powerful driver of bringing purpose and fulfillment to the healthcare team, thus mitigating the costly impact of turnover and burnout. And we have some evidence for that. I think all of us know that the fee-for-service system that incentivizes volume-driven care really feels like a death spiral to clinicians who feel like they have to run faster on the gerbil wheel. And I would argue that capitation makes us feel like we are rationing care. And the sweet spot for us is episode-based payment models for the management of conditions. And that's what I wanted to share with you this morning. I think we believe that innovation in care occurs not at the population level, but at the condition level by teams of clinicians that come together and innovate around the care of chronic conditions such as diabetes, cancer, cardiovascular disease, and in our case, musculoskeletal conditions like arthritis and back pain. It can also be used to incentivize the clinical team to organize around the needs of the patient with particular conditions rather than by physician specialty. An example in my field is many patients with musculoskeletal complaints are referred to orthopedic surgeons, which never made sense to me as an orthopedic surgeon who's been practicing for 20 years, why someone with shoulder pain or knee pain would be referred to an orthopedic surgeon. I know that if I wake up with a headache, hopefully I'm not referred to a neurosurgeon as my first stop. And we also know that patients with chronic musculoskeletal disease very commonly suffer from comorbid anxiety, depression, and other mental health issues, yet rarely, if ever, are people who treat musculoskeletal disease integrated in any way with people that know anything about the treatment of those conditions. Similarly, about 60 to 70% of patients with musculoskeletal disease also have weight management issues, either overweight or obesity, and yet rarely, if ever, do the people who treat musculoskeletal disease integrate in any way with anyone who knows anything about the treatment of obesity. So we believe that the payment model can be used to incentivize the creation of, in our case, a musculoskeletal medical home that includes advanced practice providers with specialty training in musculoskeletal disease, physical therapists, chiropractors, dietitians, and behavioral health trained social workers who can deliver cognitive behavioral therapy, and a few surgeons and other specialists that are needed for the management of musculoskeletal disease, but not very many. We have in our field extensive experience with bundle payments. We started doing bundle payments around hip and knee replacement in the mid-2000s. And after over a decade of experience with that, a Malden and Bhatt's group published about several years ago that over a decade of bundle payments for hip and knee replacement, we saw a 1.6% reduction in spending with, quote, no detrimental impact on patient outcomes, which for someone who spent a decade of my life working on that was quite depressing. I thought we could do better. And what we've realized in the process is when we bundle at the procedure level, we make procedures very, very efficient. So done in the lowest acuity setting that's safe, shorter lengths to stay, minimize avoidable complications and readmissions, and we completely ignore whether or not that treatment is the most appropriate treatment for that patient. And since much of healthcare is preference sensitive, where there's no right answer, incentivizing efficient healthcare services and procedures and ignoring whether the procedure is the most effective and appropriate treatment in the first place does not create value for patients. So we've moved upstream to condition-based payment models rather than procedure-based, and this involves a single annual payment for the management of a chronic condition, including chronic joint pain and back pain. It includes all the professional services delivered over that defined period of time, and we have accountability for outcomes, which makes us different from capitation, in that we are responsible for measuring and improving and delivering on improvement in patient-reported outcomes. In that case, it means measuring pain, functional status, and quality of life. It's always been surprising to me that we perform over 1.1 million hip and knee replacements a year in the United States, and less than 5% of the time do we measure the only thing that matters to our patients, which is pain, functional status, and quality of life. And yet no one thinks that's odd. No one in the payment world and no one in the clinical world thinks it's strange that we don't measure the only reason we do that procedure in the first place. So we need to measure outcomes from the patient's perspective in order to understand whether we're delivering value. And after 5 years, what we've seen is about we've implemented this model 5 years ago. We've seen about a 30% reduction in the per capita spending from initial diagnosis of a chronic musculoskeletal ailment, including arthritis and back pain. About 30% reduction in that annual spend, and substantial, about 90% of patients achieve a substantial clinical benefit in terms of their self-reported pain, functional status, quality of life. And that's patients that are treated both operatively and non-operatively. So to summarize, I think episode payments at the condition level not only result in better health outcomes at a lower cost, but by aligning our incentives with those of our patients, they bring joy back into practice and mitigate the devastating effects of physician burnout. Our evidence for that is our practice started 5 years ago, and in 5 years we've lost exactly one member of our healthcare team through the Great Resignation, through COVID, through all of the turnover. And why? Because people come to work every day and they get to do what they enjoy doing, and their incentives are aligned with the patients that we're privileged to treat. So thank you for the opportunity to be here this morning. I look forward to hearing from the other presenters and to getting into more detail in the discussion.
Thank you so much, Kevin. Very interesting. Next, we'll hear from a presentation from Dr. Ami Bhatt, who is Chief Innovation Officer, American College of Cardiology. Please go ahead, Ami.
Great. Thanks so much for having me. So just by way of prior life, I've been the Chief Innovation Officer at the American College of Cardiology for a year now. Prior to that, I was practicing adult congenital heart disease, so subspecialty cardiology at Mass General, and was the director of outpatient cardiology from 2016 on. Do I just say next slide, or do I have forwarding ability? Perfect. Thank you. Goal today, they've asked me to talk about best practices for developing specialist-focused incentives and performance metrics, and then how do we encourage engagement with primary care providers, which is something we talk about a lot at the ACC. Just a few facts, though, about practice today as we start for cardiology. Total value allocation, still pretty modest in specialty care, especially in cardiology globally. So just important to recognize. And the second is many practices are relying on the fact that as we build these models, it's going to lay the incentive and metric infrastructure for value payments. There's a lot of alignment of when we do this, we should all do it similarly. So I think there's a lot of importance in the discussions we have in the work that PTAC does for our field. Next slide. So developing specialist-focused incentives, what are some key things that we're finding from our membership? So the first is creating team-based value incentives in cardiology. And I would say I'm calling this specialist in general because I think this applies to some of the other specialties that are very similar to us. And it would be great to think about it as all of us together and not just each specialty deserves their own mechanism. Team-based care has really become a basis of how we deliver care. And so we really need team-based value incentives. When we don't have that, we have discussions amongst who the different team members are and who's getting credit for which RVU for what, and it's really counterproductive to the kind of care that we're able to provide. The second is we are a subspecialty that actually has subdisciplines, and those subdisciplines are oftentimes interventional and non-interventional. Other specialties have this as well. One of our challenges is that there is compensation inequality for a variety of reasons that developed over many years across those subdisciplines. So perhaps a more challenging goal is how does one compensate for the entirety of the course of a patient's care? If you look at the average cardiovascular care patient, they don't just touch one area. They have heart failure and coronary disease. They need a catheter and they need a pacemaker as well as guideline-directed medical therapy. So how does one compensate equally across subdisciplines to encourage the entirety of care? And that's changing some models, but I think that deserves some thought. The third is allocating value. Allocating value to clinically meaningful non-production metrics. Right now, most of our metrics in cardiology are all production metrics. And so that really is a contradictory incentive for what we're doing and really want to trade those contradictory incentives for purposeful achievement. So what are the non-production metrics, even in those who are not yet value-based, that people agree upon and would start to use as a cornerstone for the future change? And then lastly, I think there are specialists that know a lot and are interested in value-based compensation, but are perhaps not included as a lot of the value change happens in the primary care structures that are within their organizations. And so I think even as primary care is starting to go value-based, which we're seeing more of, it would be great if the cardiovascular team could be included in even planning those thoughts if it doesn't yet include the subspecialists, only because you then have a hand in what the floor looks like and what we were building upon. Next. Next slide, please. Thank you. And you can click 3 times for me right here. Perfect, thank you. One of the ways we talk to our cardiovascular membership, ACC is about 57,000 members, is to really talk about population-based total cost of care as optimizing patient care. So some of the pressures on our decreasing cardiovascular workforce and our burnt-out workforce is chronic management. And really partnership with primary care is patient-centric, but it also reduces low-value specialist care, which is oftentimes a lot of what's burning out our specialists. And so I think that is a great way for us to think about that partnership. I think the second is rising risk. When illness progresses and can be identified, that doesn't have to be managed at the specialty level. There are oftentimes, we have really great guidelines and closed-loop mechanisms for GDMT that can be used at a primary care or specialty practice level. And so I think sharing that rising risk management burden would be helpful. And then lastly, when patients eventually get to requiring intervention, what we are talking to our specialists about is the fact that the care is oriented to the right testing, the right specialist, the right location, because we had this partnership with primary care, with community engagement. So this has been what we've been talking to our membership about. Next slide. Separate thought. I am the Chief Innovation Officer. Clinical practice, especially since COVID, in cardiology, even a little bit before, is continuous and is no longer episodic. And so we're going to need payment models to follow this trend. You can get many cardiologists on board with this concept for outpatient care, which is we use a lot of asynchronous communication, patient-reported outcome measures, electronic consultations, patient gateway through the MyChart, et cetera. So that's really important to our mechanism of care. It's also team-based. The asynchronous communication goes to a variety of different clinical providers. Blended care, in-person and virtual synchronous visits, whether phone or video. There are many patients who are demanding the ability to do this, and they are happy with it. So even though we continue to watch, the continuing waivers and look at when phone will be covered until, which is a separate issue, it's really important that phone will likely continue. Patients enjoy it, teams see it's necessary. So we have to figure out how we're going to really account for blended care. Clinical remote monitoring with medical grade FDA-approved devices has been around for a long time in cardiology, but the field is growing. We do a lot of it. Right now, it is reimbursed by specific codes for 30 minutes of blood pressure monitoring, et cetera. And this eating away at every single little thing and then having to add them all into what your RVU generation is something that's wearing away at our clinicians. So again, another reason that people are ready to think about continuous payment rather than episodic. And then lastly, digital tracking and wearables, healthcare, social data. We'll talk in a minute about how we can maybe use some of that. And then lastly, data analytics, really thinking about collaborative intelligence and the utility of AI in helping us take large amounts of data, understanding what we put into models, understanding what comes out. There needs to be some room for us to start looking at how to use that and compensated for it. We won't use it unless it's accounted for, and I'll get back to that in a minute as well. Next slide. So health equity, really central to the ACC. I wanted to make sure we addressed it. Value-based models with adequate infrastructure can really help us. So incentivizing total cost of care by supporting upstream equity in screening and disease identification and meeting social service needs. If you look at the primary care practices, we are jealous. We perhaps have a care coordinator when we discharge a patient from the hospital in cardiology. But shy of that, we have very little knowledgeable support in how to help with the social determinants that our patients face, and that is challenging. So if there is a way that that can be incorporated in future models of care, especially if we're partnering with primary care, that would be really important. Embedding social determinants of health and social vulnerability index into payment models. We are used to doing this for risk adjusted models in terms of procedures. So we're really just looking at doing it on the other side of kind of outpatient care and looking at social determinants of health. It's something that we've gotten used to, so I think we could start to learn how to apply it and mirror it in other places. And then lastly, team-based subspecialty care, whether it's upfront compensation, whether it's subsidies or incentives, sharing it across a practice is important. You'll notice that many cardiovascular practices have the 3 people who see the majority of the Medicaid patients, right? The one who's in Boston, for example, Chelsea, and those are the 2 doctors who get all of our patients of a certain race, ethnicity, socioeconomic status. And rather than having those people have their compensation dependent on that, if a practice were to then look at compensation holistically, and if social terms of health, social vulnerability were incorporated into the entire practice, everybody gets credit when that practice does well. I think that's a concept to really make sure that health equity grows as we move to a total cost of care model. Next slide. So last 2 slides. Options. If you say, hey, doc, what can we actually do? So one that we have written and talked about quite a bit is the comprehensive condition-based value model. Episode of care from treatment to stabilization, so atrial fibrillation, right? Bundled care for MIs. We're probably going to continue to need that for some of these models based on the way we're already set up. However, there's also a continuous care value-based model. If we're collaborating with primary care, if we have community outreach, we address health equity, the 2 slides we just talked about, what does that kind of a value-based model looks like? I think we need to perhaps address our specialty with the challenge we're facing, which is chronic disease management and continuous care is a major part of the burden of what we do. And yet, separate from that, we have significant high-risk episodic care that needs to be controlled. And maybe we need to think about 2 different value-based subspecialty models that exist in parallel. Last slide, please. So I think for us, successful value models are going to address the following challenges. For accelerating complexity, we need better partnership and upstream care, whether that's with primary care, whether that's community-based, how we're doing it, so that that complex care can actually make it in the door in time to the subspecialist tertiary institutions or caregivers. There is exponential information overload, and somehow the value-based models need to include RPM and analytics rather than each RPM being its own separate RVU generating code. And so how do we actually create a model that builds for that? And we can talk more about it in our discussion. Rapid technological disruption is happening. There needs to be room for innovation. People aren't going to use the new technologies or the AI that's going to make them better at providing care because the foundation is given to them. And then clinicians use their own clinical acumen over that foundation of here's everything I found in the EHR, rather than I turned my back to my patient, spent a lot of time in the EHR and still didn't get the maximal information that it can provide. But somehow we have to account for that. If you're willing to innovate, willing to iterate, that's part of the value-based model of your care. And then lastly, we do need health equity support. So we need stronger models that incorporate people who are really specialists in thinking about social determinants of health. We can start teaching, and we have started teaching our cardiologists about this at a younger age and even in med school, but it's different to be a specialist in actually how to deal with social determinants. I think there's maybe one last slide that says thank you. Perfect. Thanks so much for having me.
Very thought-provoking, Ami. Thank you so much. Next, we have Dr. Judy Zerzan-Thul, who is Chief Medical Officer at Washington State Healthcare Authority. Go ahead, Judy.
Oops, these ones aren't my slides. This is the next, there we go. Good morning, everyone. And I'm excited to join you today. So next, I'm going to talk from a much higher level, more about systems and integrating behavioral health care. And so to give you a little bit of a background of that, I work for the Washington State Healthcare Authority. We are the state's largest healthcare purchaser. We provide coverage for Medicaid folks, public employees, teachers, and retirees. And next slide. And besides being the single state Medicaid agency, we are also the single state authority for behavioral health. And this has evolved over time. There used to be separate divisions for alcohol and substance abuse and mental health. Those two joined, and then in 2018, that division moved over into HCA. And that has really allowed us excuse me, to better integrate behavioral health care into the whole healthcare continuum, and think about how community behavioral health supports fit in, and think about how payment fits together. And so in the next slide, I'll show you who we served in fiscal year 2022. And it's important to know these are all Medicaid folks or people without insurance or low income. So our behavioral health services are really focused on the non-commercial population. And most of these folks got mental health services treatment. That's the sort of lighter blue color little people. The green people got substance use disorder treatment services, and prevention is a part of what we do, but you can see it's a small part now. We'd like to grow that, but there's a lot of need and a lot of workforce issues. Next. Our journey at HCA to whole person care has been a long time in coming. Before integration happened, before the behavioral health division came over to HCA, there wasn't any one payer or any one system or provider accountable for whole person care. There were two different state agencies that had kind of mixed responsibilities for different parts of care, and access to care standards, treatment standards, all were similar but a little bit different. And so after integration, we now have whole person care management that's provided through a single accountable managed care organization. We at HCA are responsible for that care. We've worked so that we have the whole continuum of physical and behavioral health care, including crisis services, really focused on what does the person need, what kinds of supports for behavioral health, physical health, and social needs can we support them with. And I also wanted to point out this has been a slow journey in many ways. So it started with different counties. It started with different chunks of populations, children and families, and then pregnant women we worked on first. But now we've really got to everyone. And so the next slide, I think, is a nice picture of what things look like before integration and after integration. So before integration, on the left-hand side, there was a confusing mix of delivery systems and payment systems run by two different state agencies. Some services were provided by regional mental health plans. Some services were administered by counties. These were mostly substance use disorder treatment. And then the state agency had inpatient, and things were not well connected, and people didn't get as good care as I think they're getting today. So after integration, on the other side, we have MCOs really leading the care. They work with behavioral health ASOs. They work with counties. We have these accountable communities of health that are focused on social determinants and health needs. But it makes things much easier when medications, outpatient treatment, inpatient treatment can all be coordinated. Next slide. But to get there, it has been, we've had to move carefully. So both to not disrupt services and to figure out what the right payments are. We found as we made this journey that many behavioral health agencies did not know how to bill well, and didn't bill for the full complexity of their services, which the managed care organizations that are very used to sort of crunching numbers and giving people payments, without that claims data, really struggled to make sure that they got the right payment amount. We started our integrated managed care journey in 2016 when we put out bids, and in 2018, the first two regional areas, we did it in regions of the state that we rolled this out. So the first two started in 2018, and we found almost immediate benefits within the first year or two in terms of increased housing for these folks, particularly the ones with more severe mental illness, and also immediate returns in terms of a decreased reincarceration. This population often is in and out of jails and prison, and providing an integrated healthcare really has helped people be more functional and stay in the community, which is great. We had our final three areas of the state integrate over 2020, which of course was completely disrupted by COVID. And so it has taken us a few years to have system stabilization, to figure out what the right reimbursement level is, to figure out what the right service level is, and get to integrated statewide coverage, which is where we are today. Next slide. I'd like to pivot briefly to talk about our focus on value-based purchasing and some of the ways we're doing that with regards to primary care and behavioral health integration. So next slide. We have been on a VBP journey since 2016. We use the LAN framework for VBP, and we measure categories 2B and above. And you could see when we started, we had a relatively modest goal, and that has increased over time. We continually strive to figure out how do we get better outcomes, lower costs, better experience of care for both our patients and the provider, and really reward that high value care. As we've done this, one of the things we've learned is that most people are sort of stalled. While we have impressive VBP penetration, most of that is stuck in the 2B level. So people get rewarded for quality, but we're really trying to push how do we get to population level payments. That turns out is much harder for providers to want to sign up for and want to do. And so having the right communication and the right understanding to clinicians so that they want to do this, I think has been another lesson for us. Next slide. So one thing we've been working on with integration for a few years now is primary care transformation. And this has been an aligned multi-stakeholder approach. We've had extensive engagement and working on these accountabilities you see here for three groups. The clinicians that include accountabilities for whole person care and behavioral health screening and treatment of mild disorders. We also have payer accountabilities to have aligned quality standards and move towards funding of a capitated model so that most services for primary care will be paid on a per member per month basis. And then we also have a group of employers at the table for the commercial insured lives in Washington that are really looking at what kinds of better integrated primary care do they want for their employees, and how can they support both the health plans and the providers in moving towards that. HCA here, we have a role, but we are for sure not the only one. One piece that we're doing to help advance this is measure primary care spend. Other states are doing this, and integrated behavioral health is part of what we want to spend, or what we want to measure in that spend. We have a goal of 12% of total health system spending being for primary care services, and we hope to have the first measurement of that out by the end of this year. Next slide. So to get to integrated care, you have to measure integration and figure out where are practices. And so we have developed a statewide standardized assessment tool that measures the degree of integration. And the beautiful thing about this is that we have a tool for primary care, but we also have a tool for behavioral health practices. And it's really that bidirectional kind of measurement that I think is important in this space of how do you have that communication and how do you provide services. We just finished our first cohort in doing this integrated care assessment, and I was surprised that practices were not as far along in some cases as I thought they were, and it gives us a really good idea of what sorts of supports practices need to move into full, high-functioning integrated care. Next slide. So there is for sure overlap across a number of our initiatives, and these are all kind of pieces of a puzzle that fit together in terms of how do you measure integrated primary care in practices, how do you pay for that, how do you have care coordination hubs that fit across this and are both integrated with behavioral health and primary care and the community. And we are starting to work on setting up certified community behavioral health clinics, which I think will also be an important piece of the puzzle. And I think my sort of messages as we go along this journey are integration can for sure be done and be done well. But the payment part can be tricky, and thinking about how to make sure many behavioral health practices are very small and are independent, and you don't want to make them go out of business or have financial difficulties as this shift happens. We spent more time on that than we were expecting. And then figuring out ways to make payment work because many of these things overlap, whether that's overlapping, whether that's nested models, is important. And one thing that we are still trying to figure out how to best have that payment sort of weave in and out of different models, not be overlapping, but be enough so that good care can be possible. Thank you. And I think I have one more thank you slide too.
Thank you so much, Judy. It was really interesting. Next, we have Ms. Christina Borden, Director of Quality Solutions Group at National Committee for Quality Assurance, and Dr. Brian Outland, who is Division Director for Practice Health Initiatives with the American Society of Clinical Oncology. I'll note that NCQA and ACP worked together to submit a proposal to PTAC in 2020. Please go ahead, Christina and Brian.
Well, good morning, and we certainly appreciate you allowing us to be here and inviting us to be a part of this important session on improving care and delivering, integrating specialty care and population-based models. Next slide. In ACP, we have a number of primary care physicians that participate in advanced practice models and advanced primary care practice models. And they have gained a lot of experience with being in these models. And so in collaboration with NCQA and looking at the experience of primary care, we embarked on a model that would pilot a program for coordination between specialty care and primary care. One of the important things is the aim was to improve that coordination between these two types of specialties, primary care and specialty groups, because ACP is the largest specialty society with over 160 members, and it includes a number of subspecialty societies. So learning from the experience of primary care who are in these practice models, linking them with specialty practices that go through a vigorous clinical transformation and also coordination criteria, those specialty practices will be able to learn from the experiences of primary care who have already been embarking on these types of models. And so part of the experience we found with primary care was how could we best help? There was information sharing was one of the areas where we found a breakdown. And it wasn't just in one specific area, it was in all across the continuum of care, before the referral was made, during, and even after the referral. So we embarked on this model, supplied it to PTAC, and it met all the 10 criteria of the secretary, and therefore the PTAC was able to submit it to the secretary for testing. Next slide. So a critical element of the model is collaborative care, is the collaborative care agreement. In this agreement, it will actually outline the expectations and the roles of the clinicians that are involved in this. It would help to clarify when the specialty clinician is acting as the principal care, and when primary care and specialty care are co-managing a patient. It'll also help with the communication and sharing of data. It closes the loop on that data so that the primary care and the specialty care knows what's going on in each area at all times. And it helps to prioritize this information to the clinicians. It also ensures that clarity at the handoff. When should a patient be handed back to primary care? Or when should it continue? And so templates within this care agreement will be established so that that is clearly laid out, and the specialty care and primary care has that coordination and good communication in each of these. Each practice then would establish its own internal things that will help them to be able to prove that this works well and continues to be good coordination of their patients. So clinical features and collaborative care agreement is certainly important. In here, it will utilize these agreements with the primary care and specialty care, and it'll help to clarify when the specialty care is acting as the primary clinician. It'll also provide communication data and protocols that clearly establish what these agreements are, the mechanisms for being able to do that and prioritize based on urgency. Each practice should establish its own internal things. And can we go to the next slide? So within this care, there is a spectrum of primary and specialty care. And so it ranges from the simple consultation all the way back to the management of coordination of care back to the primary care from specialty care. So within that, what happens? There could be co-management that is shared care. So in certain instances, the specialty clinician for their long-term management of the patient will perhaps serve as the patient's primary during those times. There's also times when this co-management will be managed by both the specialty care and primary care at the same time for some long-term chronic conditions that the patient may have. There also may be a consuming illness where just one specialty could then perhaps be serving as the primary care, or their condition is worsening, and so they will take over the care of that patient. But it still keeps the primary care physician in the loop as to what's happening so that they can continue also caring for the patient's needs. And then the transfer back from one specialty care to the primary care. Next slide. So each type of shared care has its unique types of things that have to be done. But there are some things that should be in all of these types of care when the care is shared by patients. Principals. Well, who is principally responsible for the care? Is it the primary care or is it the specialty care? Who is principally responsible? So the care agreements will help to close that loop to be sure who's responsible for the principal care of the patient. Shared expectations. This is when a consuming illness may require that the principal care and co-management is co-managed by both the primary care and principal care. There are also critical elements that needs to be done from the primary care. What is involved in the primary care sending information to the specialty care so that they receive everything that they need to be sure that they have the right patient and the patient is seen at the right specialty care for their services. And then there's also helpful elements, as we mentioned, templates and those types of things that can help close the loop on the coordination and information back to each of the clinical teams. Not just the primary care sending information to the specialty care, but also specialty care getting that information back to the primary care. Next slide, please. So one thing that needs to be done is encouragement of the specialty practices engagement in this. So how can we do it? Well, any model that is created has to be understandable and predictable to the specialty care, but also to primary care. And then it has to have a foundation that is able to be worked on, that has similar framework that each can understand. And also it must be scalable to different types of practices so that they can all use this type of a model. Communication, as we have mentioned, is key in this. And so the specialty care should be involved in pre-screening of all referrals with the accompanying documentation. That is where the primary care will be sure that he sends all the needed information, because then it will help being sure that the patients are seen, and then also help lower the cost of unnecessary types of visits and unnecessary time for the patients being able to be seen within the specialty practice. Also, care coordination agreement are important, as we already mentioned, and the reimbursement structure is also important. But while that's important, even more so is the reducing the unnecessary and duplicative work. So when the primary care sends the information over to the specialty care can then triage those referrals. And maybe it doesn't need to be a full-on visit with that patient. Perhaps these things could be happening, taken care of just through a consultation or other means, or perhaps it's just not the right specialty that received that patient. And so the duplicative work does not need to take place. The patient can be sent to the appropriate place, specialty to take care of those things. Also, in total cost of care, it would be a way to encourage specialty practices to be involved from the patient level, would get the patient involved, because they could do things like waivers, transportation, and those types of things, so that when the primary care refers them to that specialty practice, they will be able to go there and be involved in their care as well. And then these specialty care and primary care will certainly work together because of total cost of care. They will know, the specialty cares will know that the primary cares who are already involved in these types of training and practices are doing their best, and will help them to be able to do their best to succeed in total cost of care type models. Next slide, please. So how to operationalize. Here are some of the critical elements that the primary care physician would be involved in. Making sure that he has all of this data, and that this data is then transmitted to the specialty practice for the referral. When the specialty practice receives this information, then the specialty practice would then be able to go through and triage and know, is this a patient for my practice? Does this patient, can I handle this problem or this illness just with a consultation with the primary care? Or can I send this patient to a different specialty that will actually be able to take care of that? As the doctor mentioned earlier, that you don't have to go to an orthopedic surgeon when you could perhaps have had it done elsewhere. And so it will get to the right person at the right time, and then lessen even the wait times for those patients being seen in their practices. Next slide, please. Next slide is, yes, thank you. So here it helps us to appreciate that the specialty care is also involved, and what happens, some clear indications, what the specialty care is doing, what the patient is instructed to do, and what the referring physician needs to do and when. And so all of these things will come back from the specialty care to primary care to help close the loop so that the primary care stays involved with the patient's care as well as the specialty care being involved and both working together for the benefit of the patient. Now I'll turn it over to my colleague, Christina Borden.
Thanks, Brian. So the next couple of slides really speak to the execution and many of the things that Brian also addressed. The intent of the standards that are outlined for how to set up those collaborative care agreements is really to ensure that when patients are referred to any specialty, that the clinicians have the information they need to appropriately answer the clinical question, know the patient and how to treat the patient, and establish those roles and responsibilities between clinicians. As part of this coordination, there are expectations with the referring clinician and verifies that they have received the information needed to appropriately diagnose and treat the patient. By verifying that the clinician has received the pertinent clinical information before the patient is seen, the practice can really reduce the need for duplicate work, such as collecting demographic information and lab or imaging test results. So payment models should really incentivize care coordination compacts and collaborative agreements upfront so the duplicative costs are avoided and it disincentivizes duplicative testing. Next slide, please. So this is guidance on how to really establish those relationships, and routine and effective communication with primary care and other referring clinicians is the cornerstone of the medical neighborhood. Collaborative care arrangements focus on any specialty practices engaging with primary care and other referring clinicians that the practice frequently receives referrals from to set expectations around how and what information is communicated and exchanged. These relationships should be formed from all types of referrals. If you go to the next slide. This is an example that shows some sample language on how that collaborative care agreement can be formed between the primary care and specialty practices. So this covers the collaboration on patient care and the transition of care as an example. If you go to the next slide. Once a clinician or practice receives a referral request from another provider, then there is a need to confirm that the clinician or practice has the details about seeing the patient. This begins the tracking process workflow for the specialty practice. And this is being done exactly the same way on the primary care side. This is where it was established, kind of the processes for how this happens. But in order for clinicians not to feel out on an island, everybody needs to be doing this, and it really helps to support the care coordination aspect. If you go to the next slide. The expected information on a referred patient is detailed as part of the referral agreement and the care compact. The intent is that both the specialist and referring clinician understand their responsibilities and have a plan for communicating to the patient. For the communication responsibilities could be captured in the assessment plan in, for example, the patient's EMR. So really, does the patient have access to the assessment plan and section so that it's not just being communicated between clinicians, but making sure the clinicians understand how and when they're communicating to their patients. The follow-up information, when not received, might also be a part of the process. So think about it as those red error messages for what is missing and the required information not provided that probably needs to go back to the primary care clinician or the other referring clinician. As we know, it's not a perfect world of seamless data sharing. The patient's demographics should include communication needs, primary language, relevant cultural, ethnic information, date of birth, sex, contact, and health information. Clinical information should include the patient's problem list, current medication, allergies, relevant medical history, mental health, substance abuse issues, and behaviors affecting health, for example. And so these were just how those collaborative care arrangements can be set up between clinicians. And then Brian's going to go into some case studies showing the benefits. So Brian?
Here it helps us to appreciate the benefits of using the collaborative care agreements within this type of a model. A ACP member led endocrinology practice from Colorado. As a result of using the collaborative care agreements information, their clinical questions increased from 0 to 75%. And what did this do? This helped them to then reduce or increase their supporting documentation from the primary care from 30 to 60% within 6 months. And then because of that, it reduced the insufficient information that was supplied in referral appointments. That declined from 70% to less than 5%. And then it was able to help them to save from doing duplicative testing as well as associated cost, and was able to save even the patients on having to do cost sharing on unnecessary visits. So by receiving more complete information and utilizing this, it helps to see that appropriate referrals went from 20% to nearly 0 because they were using these collaborative type of agreements and closing the loop on the referral process. Next slide, please. Here's another case study from a rheumatology practice. It showed that they found that at least 4 in 10 patients did not actually require a rheumatology visit. It could have simply been handled without or with just a consultation without actually having to see the patient with their primary care physician. Again, helping to see that the appropriate referrals improve the practice access and the efficiency and profitability and was maintained because of proper patients could be seen and scheduled sooner. And the backup and the wait times for patient was much less, reducing healthcare costs and addressing the personnel shortages and improving access because they were using these principles. Next slide, please. So payment is certainly critical in this. So the medical neighborhood helps us to appreciate that patient collaboration and agreement with the referral is appropriate. Referring to the appropriate specialty practices. Specialty practices can then pre-screen with the accompanying documentation, having all that they need. The visit then triggers an active phase of attribution, and the specialty practice role may vary, but they could also co-manage the patients. Next slide, please. And there are 2 tracks that were set up for this and for the payment, which is similar to what many of the primary care physicians were in their specialty practice, specialty type advanced practice models. And it will be nice for them to be able to link along with the specialty care practices. So there are many benefits to a model such as this in linking primary care and specialty care together and helping them care for their patients. Thank you for allowing us to be a part of this session today.
Thank you so much, Christina and Brian. Very interesting as well. So now I'd like to turn it to the committee members. This is our opportunity to ask questions. It's been very rich presentations and many different directions we could go. If you'd like to ask a question, please turn your name table tent up. And also for our members online, please just raise your hands. So I will open it up to the committee. Who would like to start? Jim, please
Sure.
go ahead.
Thank you. Dr. Bozic, thank you for your presentation. One of the things I was struck by, and just wanted to be curious, I'm from Dallas, Texas, and was really impressed with your design, is how do you see scaling what you're doing at UT Health Austin and the Musculoskeletal Institute to be a sub-risk contract entity, specialty entity with PCP-based ACOs in the Austin area or in the state of Texas? Can that model be scaled, and how might you think about that, or have you been thinking about it?
Yeah, thank you for the question, and it's absolutely an aspiration of ours. We have a national payer and purchaser coalition that we've been working with now for about the last 4 years. Mark McClellan from the Margolis Institute and I lead that effort. And we've been working through a lot of the blocking and tackling in terms of defining the condition-based bundles. So the trigger codes for the start of the bundle, the inclusion and exclusion, the risk adjustment, and so we are actively seeking partners to do pilots with. And at the same time, we've had a number of discussions with purchasers, so large employers. ACOs are a perfect partner for this. It's essentially subcontracting out your risk for specialty care with a locked-in, guaranteed discount on your historical spend on, in this case, musculoskeletal care, which accounts for anywhere from 18 to 23% of the total spend of many ACOs. We can lock in a lower because we know now we have enough experience with our model that we know at the population level that we're going to reduce spending primarily through reduction in utilization of surgery and without compromising on patient outcomes. So the short answer is yes, we're very interested in scaling and we're looking for partners and would love to speak with you offline and even involve you in that coalition.
And Walter.
Yeah, just a follow-up, Dr. Bozic, to that response. Really interesting work. I guess my question is, most of our patients have just more than one condition, and it's great to think about a condition-based payment model. But what happens when patients have, 5 to 6 different specialists? They see an orthopedic surgeon, a cardiologist, an endocrinologist, a pulmonologist, a nephrologist. Are we suggesting that each condition has a medical home, so to speak, with payments paid to that medical home, both from a condition perspective as well as a acute event or major episode perspective? That's part one of the question. And part two is, how do you, through this condition-based payment model, incent appropriate preference-sensitive care? So, for example, the orthopedic surgeon still gets paid more for doing a total knee, I presume. Is it a discount? Is that how you control utilization and incentives that way? How do you control volume of procedures in that payment scheme?
So let me start with the second question first, because that's pretty straightforward. Actually, the orthopedic surgeon does not get paid more for doing a procedure. We get, and it's team-based care and team-based payment. I know one of the speakers mentioned this early on. We can't even track utilization by individual clinician. I don't know how many work RVUs or anything else I'm producing because it's all team-based care. And so we get an upfront payment, prospective payment for the management of that condition for the year, and there's no incentive, there's no additional professional fee payment whether we do any kind of treatment, whether it's physical therapy, injections, cognitive behavioral therapy, or surgery. But we are held accountable to the patient-reported outcome. So if surgery is indicated, we do it. Our utilization of surgery is about 30% lower than the population average, not because we're more conservative surgeons, it's because we have more treatments to offer. Most practices that treat musculoskeletal disease can offer surgery or SORI, and we can offer them lifestyle modification, help them with weight loss, help them with cognitive behavioral therapy to retrain how they think about pain, and lots of other treatments that aren't just surgery. Your first question around how do you think about, multiple patients don't show up with one condition. They show up with multiple conditions. I think it's a great point. I would think about it no differently than how, if you're a primary care physician, you're referring a patient for the treatment of a musculoskeletal condition, you're referring them somewhere else for the treatment of cardiovascular disease, et cetera. It doesn't change that at all. It's just that you're now being referring them to a place that treats the condition more holistically and recognizes that there are multiple different factors that influence the outcome of treatment for that condition. And so you've got a multidisciplinary team as opposed to an individual specialist. But it doesn't take away from the fact that, yes, that patient needs similar treatment for their cardiovascular disease. It could either be done by a single individual specialist or a team like this. And I will say that, from a patient perspective, I think the comments that we get are really, pretty rewarding to hear how patients feel about this. If someone comes to us, we screen for anxiety and depression. If we identify someone with a, severe anxiety or depression, we don't treat that condition. We get that plugged in with the appropriate mental health, but we have to understand how the treatments that we may offer for their arthritis, back pain, or other things are influenced by that condition. If we completely ignore that, we're not going to be delivering value for patients. So we're not taking over the management of all of their comorbidities. We're just acknowledging that those comorbidities influence the outcome of whatever treatment we're going to offer for that chronic disease. So hopefully that answers at least some of your question.
And Walter, just checking, did you also want to hear from Brian and Christina? You mentioned the medical neighborhood, and just want to clarify that your question was answered. So Brian, Christina, would you like to add in?
Well, this is Brian. I will add that is based on that question, is one of the things that the medical neighborhood model certainly tries to do is link the primary care physician, perhaps as a medical home for the patient, so that there's one person who knows everything about the patient and things that are going on to the specialty care, and then be able to work with those specialty cares so that somewhere along the way, this physician or that physician or group, everybody can say, oh, I'll send my information here. They have it there. They have a medical home. They know where the information is coming and going, and the loop is closed on the patient with their referral information. And also the specialty practices, through their agreement, will know which specialty is caring for which type of condition the person may have, because all those things are listed within the specialty care agreement that they will have with the primary care. So they can contact and be able to coordinate with the appropriate specialties that are handling those conditions.
Yeah, and I'll just add, this is Christina. I mean, I think it's, for these collaborative care agreements, it's really important for clinicians to be able to communicate with each other around the different pieces that we described, but it really ultimately benefits both the clinician and patient. And from the medical home neighborhood model, like Brian mentioned, the primary care provider is really that sole source of information about knowing everything about the patient, and then they can share that with the specialist, so that when the patient actually goes to the referral, it is being seen by the specialist. It's not starting at step one, and they can see that there is coordination and collaboration between their clinicians, which gives patients peace of mind as well. So it benefits both the clinicians and the patients. So we should set up payment models to do that.
Thank you. Angelo.
Yes, thank you, Lauren. So my question is, I think, mostly for Dr. Bhatt. So you mentioned team-based incentives, which I liked a lot, and equally across the specialties, and then mentioned valuing non-reimbursed care and processes also. So I really have kind of two questions. Can you describe a little bit what that might look like across multiple specialists being involved in non-value, non-paid services? And then the second part of the question is, in that team-based approach, do you use navigators, care management teams that actually cross specialty service lines, or how do you do that?
Yeah, great question. So first, let me just say, Kevin, I'm in awe, because wouldn't it be great if I didn't know the exact downstream revenue of every single member of every cardiovascular practice? But that measurement it's like an addiction in our field right now still. So to your excellent questions, I think starting with thinking about what a team-based, within cardiology, just for a moment, I'm going to separate it from primary care. For example, a majority of our heart failure patients will be seen by both the heart failure and the electrophysiology service, right? They will have some sort of pacemaker involvement or atrial fibrillation ablation procedure. And what we're currently doing is heart failure can have metrics, which are generally based on readmissions, and then or touch points. And then EP will have maybe an AFib metric, which is kind of value-based from beginning to end of AFib, that doesn't really account for the heart failure metric. So could we, at a very simple first step basis, combine whatever we think the appropriate AFib management metrics are and the heart failure management metrics for that patient across the division, such that if that group of patients meets them, the entire division benefits from that, right? Or the entire clinical practice. Sorry, I'm used to saying division being a Mass General, but the entire clinical practice benefits from that. I think that's like the very first step in cardiology of getting towards what will eventually be value-based care. But I think it's doable in our conception. So I hope that helps a little bit just in the logistics of thinking about it. I think in a larger way, if you look at, either hospital readmissions or even if you look at individual patient experience, probably, we've had numbers that vary, but at least 25% of heart failure patients are followed by primary care and not by a cardiologist at all. And so I think when we go back to the, medical neighborhood model, I think that's going to be essential for us to be able to really deliver the kind of care that those patients need. What slightly concerns me is we have a workforce issue in cardiology that is significant, as we do in primary care. And so we need to figure out how the team interacts with primary care. And some of this for us is actually very cultural. I didn't bring it up in the presentation, but I'll say it's very cultural. So if you're a primary care practice and you're relying on the cardiovascular team, we really need to teach a lot about the members of the team and being okay with whichever members are there and how we're communicating, or even using remote monitoring closed loops. And the cardiovascular practice trusting that if the closed loop tells the community practice something in the medical neighborhood, we've already vetted it, we have to trust it. We can't see that patient to make sure the remote monitoring worked, because that really works against the entire concept of how we measure together. So I guess two separate answers. One is we have metrics that are very subspecialty focused, and we need to start at a minimum grouping them and then having everyone be responsible. Number two, the medical home would be essential, but we need to be okay with remote monitoring and okay with team-based care as the go-to for those medical neighborhoods. And there's still some culture change that needs to happen there from what we see. Does that kind of answer those questions?
Yes, thank you. And if you could comment, and you may not be there yet, but how are you using navigators across specialty lines? Are they more siloed, or are they working across specialties?
Those of our cardiologists in the ACC who practice in multi-specialty groups are the ones that the rest of us are looking to and saying, gee, we wish what you had. The majority of practices do not have cross-specialty navigators at this time, unless they're in an employee-based contract, unless they're already value-based, unless they're part of like a Pioneer ACO or something else. It's 25% of the 100% of what's happening, and the other 75 is RVU. So we're only seeing navigators where really value-based care or comprehensive employee-based care or multi-specialty practices exist, which is still a minimal percentage, as I started in my first slide, of the majority of the practice of cardiovascular disease right now in our country.
Thank you.
But we would love it.
And Larry and Lindsay, who was first? Larry, please go ahead.
Okay, well, great presentations. I think my question could go to just about any of you, but probably to Dr. Bhatt or Dr. Bozic. I'm intrigued by your team-based care. I love the concept. I can see how it could work. But your cardiology is a specialty that's become heavily employed. And the number of independent cardiology practices out there has been dwindling over the last few years. How do you implement team-based care in that community practice setting where doctors aren't, as Dr. Bozic said, oblivious to their RVUs? They are totally tied to their RVUs. How do we implement this in, I guess I'm going to use the word, the real world, rather than in the controlled situation?
Maybe I can take a stab at it first. So I think, if I understand your question, it's simpler to implement in the employed model. Is that what you were referring to? Yes, I will say, so in our case, unlike cardiology, the majority of orthopedic surgeons are in independent practice, are not employed, although that's changing pretty rapidly. New graduates are joining employed practices, but we work closely with the Orthopedic Forum, which represents all of the large orthopedic practices in the country. It's about 60% of all orthopedic surgeons. And they look at this as an ancillary service. So just like they would own an ambulatory surgery center or an MRI or a physical therapy practice, owning a musculoskeletal medical home allows them to take all comers, take risk, and out the other side of that comes patients who are appropriate for surgery. It's actually extremely rewarding from a specialist perspective because you're not being the frontline musculoskeletal care provider dealing with patients with chronic pain, depression, obesity, opioid addiction. You have others on the team that are doing that, and then if and when they're appropriate to consult with a surgeon, we bring the surgeon in. So from an orthopedic surgeon's standpoint, it's a dream, and it allows you to get involved in risk upstream and rather than setting a whole bunch of criteria that say only send them to me if they've done this, and this, and they're already been talked to about surgery and they're ready to schedule surgery, which is what a lot of orthopedic practices do. Now we can say, give us all comers. And that is more attractive to an ACO or another risk-bearing organization.
That was a really positive outlook, so I will give a more tempered version. The RVU model, as it exists in community practice, does not support team-based care the way we're thinking about, because you earn what you earn. However, if models increase volume of what comes through, increase patient interactions without having to increase the physician-patient interactions, driving towards administrative burden, burnout, documentation. Some places have been successful in doing it. When you talk about who is involved in team-based care, there are team-based members who require a larger salary, and then there are team-based members who don't. And so varying who that team is something that we're seeing practices start to really think about. Using somebody who has a very high license to do work that would be better done by a social worker, thinking about the role of LPNs, really thinking about the role of pharmacists and partnering with pharmacists or recent pharmacy graduates. I think we're starting to experiment with varying who that team is and what the exact need is in the practice in order to, however, increase volume and decrease burden for the physicians in the practice when they are straight RVU, right? So you're still driving from RVU, unfortunately, until you change that model. There was a second commentary that I had. Yes. The other side that has created a lot of discussion is when you have primary care practices who have subspecialty needs, is there a role for using other team members that are not clinicians? And that has engendered just considerable discussion from all ends about whether or not that's a model that's going to work. So I'd maybe just leave that at that. And then I think lastly, remembering that our specialty, perhaps GI, maybe pulmonary, a few others, we don't have the benefit of a little bit of what Kevin's talking about with the team, which is we have interventionalists and then we have chronic disease, complicated care managers. We have two totally separate, the heart failure transplant doc really is worth as much as an interventional cardiologist, but it is harder to understand what that looks like in those two models. So if you can be in a lab all day, like you can be a surgeon all day, sorry to make that, but then yes, somebody else should be in the office. At MGH, we ended up having to give stipends to interventionalists to go to clinic, right? Because if you have to choose where you want to be, you're trained to do a certain thing, you want to do that thing. Some of the questions are maybe low value care for the 35 years you spend in training, we understood it. And so again, I think that gets back to what you want to do with your time, and the interventional versus the non-interventional groups almost are treated a little bit differently, to answer your question. It's complicated.
Thank you so much. I'm going to go to Lindsay next. And just a note, we have about 20 more minutes. And there is so much rich dialogue here, but I want to ask everyone if you can ask your questions succinctly and think about your answers in that context. Go ahead, Lindsay.
Thank you so much. One theme I heard really layered in all of your presentations is this theme of making sure that the specialist that is highly trained to do, something they've spent years training to do, gets the appropriate referral. So whether that be through the lifestyle changes that happened before the surgery, or the social issues addressed, or just the appropriateness of the referral through use of e-consult. I think my question, and Dr. Bozic, your work is amazing. I love it. I think it's the condition-specific treatment is a wonderful solution to kind of layering onto our current fee-for-service world. My question comes to, is there the workforce to scale a team around every specialist, and does the payment for a condition flow there versus flowing to primary care so that they can do more in primary care and get patients when they've exhausted the cognitive behavioral therapy, the diet and exercise? So that same end result of the surgeon being utilized when it's time for surgery or when surgery is appropriate. Maybe we don't know the answer, but I guess for Dr. Bozic in particular, I'm curious, what do you see as the advantages of embedding that team together with the surgeon, as opposed to providing more robust payment in primary care so that it would do some of those first, second line things before surgery is available?
I think it's a great point, and I think you can do either. I would only consider having condition-specific medical homes for something that a primary care practice has a large part of their spend, right? So musculoskeletal, cardiovascular, the usual ones that come to mind. Could a primary care physician manage, chronic musculoskeletal disease, which they do? It's the most common reason to present to a primary care physician. I would argue that, to put them in the position to say, okay, I've got to stay up to date on the current treatment for musculoskeletal disease, non-operative and operative, and know what's the trigger point at which point I should make a referral, puts a lot of pressure on them, and it's not their expertise. We have advanced practice providers that spend their entire career treating musculoskeletal disease. They're integrated in a team with all of those other different treatment options, so they don't have to be referred out for physical therapy, referred out for CBT, referred out for weight loss. And so I think historically the reason why those referrals are, historically the primary care physician would say, I'm going to hold on to this patient as long as I possibly can, because as soon as I send them to a surgeon, they're likely to have surgery, which is usually the case. And so this model, we can guarantee a lower rate of surgery, and we can provide all of the wraparound services for that condition and still keep the primary care doctor in the loop. So it's just offloading their risk for managing certain conditions which make up a big part of their spend, but including them in the process. It's not cutting them out. That's my view.
I'm sorry, I know Dr. Pulleru has her hand up. I wanted to take that and send it down to Brian and Christina for a second. Sorry, down because you're down on my screen. I worry sometimes if Kevin's going to, or if our practice, Kevin's practice, others are sending this volume first to primary care, and we have a PCP shortage, we have a nursing shortage. Is there capacity? This question comes to me a lot, and I'm just going to ask, is there capacity for primary care to be able to do that level of management of whatever we're calling, lower acuity care in collaboration with us or not? I think that's one of the things people worry about in our field, the specialists, sometimes why we don't let go.
Yeah, so this is Brian, and at ACP, the American College of Physicians, where much primary care takes place, we do agree that there is a shortage in primary care. But the model that we've worked on, and our physicians do feel like they could handle that work. As a matter of fact, it would make it it would relieve some of their burden, because sometimes they hold on to their patients because they don't want to refer them, as the doctor mentioned, that they may get surgery and they not sure, or they're just receiving patients and they're holding on because they don't know who to refer them to in the field, because other specialties have shortages. And so this way, by creating that agreement, they're able to review and say, I'll send you here. And then maybe it's a consultation as to how best to manage that they don't have to do it on themselves. Or maybe then it goes to someone else and they say, okay, I'll take this person and I'm able to manage it. And so that takes it off of their plate. So I do feel like they can handle this work. It's just being sure that the coordination and collaboration is there, because they're not feeling like they're, in many instances, kept in the loop of their patients when they do refer them out.
Yeah, I don't have anything additional to add other than for the clinicians that have come through our patient-centered medical home and especially practice programs that's part of the patient medical neighborhood. Just as Brian said, having those understandings between clinicians of when it is good to have a consultation versus a direct referral and building those relationships over time just make it more and more seamless. And so that it just becomes natural of when you know when you should be doing a consultation or actually making a referral. And I think definitely for specific types of conditions, it's easier for primary care to automatically just kind of handle it, like when it comes to like diabetes care, for example. But there are going to be instances where you need to navigate the patient to that actual referral, and having an understanding of who actually will be a part of that collaboration and coordination is another aspect. You just don't want to refer out to anybody, but having that relationship with somebody, with another clinician, and to be able to coordinate for the patient is very important. But I think we've seen that clinicians have that capacity to be doing both, to be both part of the consultation, but also making the referral that encompasses everything that the clinician needs to know.
And I'd like to just jump in here, having worked with primary care practices pretty deeply on our model the last few years and being a primary care provider myself. I think the reimbursement for primary care isn't there to have the social worker, to have an extra nurse care manager, to have a peer navigator, all within that practice. How we currently reimburse primary care in our fee-for-service system just doesn't allow for that. There's not extra. And so there really need to be alternative payment models so that you can have that full team of people. And I think there's some good programs that are working on, including in Washington State. How do you grow that workforce? How do you grow that lower level workforce to provide that kind of care? And I think that's definitely possible.
And I'm going to just quickly check. Jen, Josh, Chinny, Walter, are any of your questions for Judy? Josh? Okay. I'm going to go to Josh next then.
Great. Judy, it's good to see you. I think I've really enjoyed everyone's comments about how, integration happens at the clinical point of care between clinicians and their teams. But one theme that keeps coming back is, to me, is a sense of knowing who you're referring to, knowing the capability of the teams, the clinic, knowing that Kevin has a musculoskeletal institute rather than a different type of orthopedic practice. So Judy, your comments about this integrated care assessment and how Washington has tried to step back and try to understand the capabilities of clinicians and their groups, I think is really striking to me. I was wondering if you could comment on that briefly. And you mentioned it, you're thinking about payment models as well. That's what our committee's thinking about. So if we believe that assessing capacity, right, is important as a very first step, how can that interact with models? Either how can that assessment kind of help groups and policymakers think about where to target those models based on capability to integrate, or vice versa? What can payment models teach us about how we need to assess integration?
Josh, thanks. It's good to see you too, and a great question. So I think one thing, especially thinking about this first cohort of primary care and behavioral health providers that we did the integrated care assessment on, it was surprising, although maybe it shouldn't have been, that most providers were on the very early tier of like, they give people a PHQ-9, they screen for anxiety. But then like the next steps after that, there were very few. And so I think that sort of speaks to my last comment of like, there's not this extra money and there's not this extra workforce to figure out how do you have a handoff to someone of like, oh, this person has depression that's more complicated than what I can do. How do I do that? You may know, but I know others on the committee don't know, part of our primary care work is figuring out some of this assessment. And we've been talking for a little while about a certification model or a readiness model to sort of say not everyone is advanced primary care. Like there's a whole range. And we've started in our model to sort of lay out a first level, a second level, and then a third level, which is advanced primary care, fully integrated, all the bells and whistles, that sort of thing. And so, and we imagine that there would be different payments for that, because I think the practices that are very early in this journey and are not very integrated, they are completely dependent on fee-for-service. And so they need additional funding to help them. And they need some education and understanding of how the risk works, how they would manage a more global payment or a capitated payment. Some of the ones on the advanced end are ready for that. And then some of the ones in the middle are like, ooh, maybe what's this going to look like? I love my RVUs. That's what I know. We really need to think about how do we sort of move them out of that? And we've been thinking about it as sort of a continuum, that you have to have these steps along the journey, and you have to, before you get to like what kind of payment do each of these get, you have to understand where they are and what kind of care they're providing today, and then how you get them there. And you know, there's been a lot of conversation. Do you just jump in and force everyone into the pool? Do you ease them along? We've sort of thought about, and we haven't implemented this yet, but a kind of 3-year runway, so that like you have to get there, but we'll give you a little time to get there, recognizing practice change is hard.
Angela, is there anything you wanted to add later on with your?
No, I think she answered my question.
Jen, please go ahead.
So thank you so much to each of our presenters. What I'm thinking about is, you know, our 2 days have been spent thinking about how to integrate specialty care into total cost of care population models. And this session in particular was focused on developing financial incentives to do that. So Dr. Bozic, what I want to acknowledge is I think you've done exactly what we've asked, and that's put forward a model that is not only successful, but shows how specialty care can ultimately be integrated in a model, nested or not, as we've talked about over the last day or so, in a total cost of care model. What I think is interesting about the model that you've proposed are a couple of things. You know, one is, as we all know, with mobility, that there are positive secondary outcomes that occur that you just described around reduction of pain, influence on mental health conditions like depression, and ultimately weight loss, which has impacts in other areas like cardiovascular care, for instance. But what I am struck by in your model is the fact that the primary outcome measure is one that's a patient-reported outcome. Pain, functional status, quality outcomes. I think that's really unique, really special, and important to all the other process measures that we just talked about. That said, what I'm mulling over is how is that scalable to other areas or specialties? Larry, for instance, has presented to us before about a gastrointestinal model that the patient-reported outcome for a Crohn's patient is, you know, less days of diarrhea. That also makes sense. A patient doesn't want to have that symptom. But when I think about cardiovascular care, less days of AFib may or may not be meaningful. So anyway, I'm curious about, again, there's some really interesting and important principles that I think that we can all align on. There's a model that shows what financial incentives can do, and that's exactly the space we want to be in. Great care incented by the right model. But I'm curious your thoughts around scalability to other disease conditions.
Yeah, thanks. I think that patient-reported outcomes, as you point out, can be specific to the condition. That said, the work from the PROMISE group and others have shown that probably a lot of these are measuring the same thing, and so we might not have to have disease-specific patient-reported outcomes. I think that if understanding why the patient is presenting for care in the first place, and then are we actually addressing what's important to them is really what I think about when I think about the importance of patient-reported outcomes. They're not mutually exclusive from other clinical outcomes. You may have hemoglobin A1C and other things that you want to track as well, but particularly for musculoskeletal disease, if the only reason the patient's coming to see us is because they're having pain and limitation in function that's impacting their quality of life, and we're not measuring it, I don't understand how we could ever expect to deliver value to patients. The biggest challenge we have is patient-reported outcomes don't fit neatly on a claims form, and so that's a big challenge for us with payers. And we've done things like work with payers. We did this in California to require the measurement of a patient-reported outcome before approving a surgery. So it's basically it's a waiver of prior authorization. Instead of saying, did you do this, this, and this, did you even measure the thing that the patient cared about in the first place? 95% of practices don't. And so it seems like a simple thing, but it's a barrier. And I think there's a lot we can do synergistically with payers and purchasers to incentivize patient-reported outcome measurement becoming more integrated into routine clinical practice. In fact, the American Academy of Orthopedic Surgeons has a large initiative right now we're working on to try to do that with electronic health records and payers and others.
Jenny, you had your hand raised previously. Did you have a question still?
Yeah, I'll try to make it quick. So a lot of the conversation around specialty integration, and particularly procedural, one of the things that I was curious how you guys address, and Dr. Bozic and Amy, I believe, Dr. Bhatt, I believe I'm sort of directing this to you. How do you negotiate site neutrality type of things? Like, for example, in order to get a lower cost of care, you have to have the place of service matters, right? And so surgeries that are outpatient versus hospital, and you have multiple stakeholders that need to either, it's a revenue thing for hospitals to have surgeries in the hospital or CATs or whatnot versus outpatient. How are you negotiating that as you're putting these plans into place?
Amy, why don't you take that? I've been talking a lot.
Yeah, I think one of the most important things, at least for cardiovascular, is actually our time to procedure is strongly related to the likelihood the patient does well and outcomes. And so that has helped us drive a little bit in terms of being okay using a variety of locations. Now, we do not, so there's two big things that we are discussing in our field right now. I'll start with number two, I'll go back to number one. The use of ASCs for invasive procedures like interventional cardiology is still lagging. We haven't really, started to come to terms with that the way a lot of the other procedural subspecialties have. And we talk about, the why, and there's a variety of things, but financial actually ends up being at the top of everybody's list every time we bring it up. So you are right. However, having said that, there are within systems or practices opportunities for us to save on dollars by being at outlying institutions within a system. So as somebody mentioned earlier, we don't have as many individual practitioners, right? Everybody's employed now, but even employed hospital systems have less expensive hospitals and less expensive community centers that are part of our network. And so in those networks, you really realize that we're pushing a lot of care out into the community where people live because we can get it done faster. It's just as good because it's the same people who are working out there as are working anywhere else. And the patient satisfaction is generally greater when you're not coming into the larger institution, but rather in the community affiliated hospital. So in those models where we have, everybody is invested in the same concept and the same thing, it's working fine. ASCs have not really taken off for us just yet, partly for the reason you said. I wanted to go back for 1 minute. Oh no, I forgot it. All right, when I remember it, I'll come back. There was another thought based on what Kevin had said. Kevin, I'll turn over to you.
Well, I know we're at the end of time. I'll just say, I think site, and this is me speaking, not the AAOS, I think site neutrality is incredibly important for delivering value. Right now, I work in a health system that we literally measure and hold hospital operators accountable to how many joint replacement procedures they can keep in the inpatient setting, not HOPD, not ASC, because the margins are astronomically higher in the inpatient setting. Once you flip to the HOPD, they drop. And then once you go to the ASC, you're at least losing 50% of the revenue because you don't own 100% of it, and the margins are even lower. And so there's strong incentives the way the payment system's set up right now to keep procedures in the hospital and not in the lower acuity setting that's more convenient for patients and more appropriate. We learned during COVID that we can do a lot of procedures safely in the ambulatory setting, but to do that, we have to partner with health systems to say, what can you backfill with high complexity, high acuity care that should stay in the hospital rather than keeping low acuity care in the hospital, which is not good for patients and is certainly more expensive.
I remember the second thing, but I just want to add back to Kevin. We are forcing, right? We are forcing low acuity care into the community hospitals where we have systems. And so I think it is happening, but I'm not sure what will happen with ASCs. And I don't know that we'll get to site neutrality with ASCs because it's such a different model. I just wanted to mention the proms. When we talk about taking what Kevin's doing, moving it to other subspecialties and scale, there is a large effort in cardiology to take patient-reported outcome measures, which we've had for a long time and are very good, and really push those to be one of the ways that we judge value, even within fee-for-service, RVU-based models. So I think that will come first in cardiology before a lot of other things that are value-based, because our patients are pushing for it, and so are we. We're also pushing for it internationally, FYI. To really get the same, especially in heart failure, the same metrics be the patient-reported outcome measures kind of globally that we look at. So I do think you'll see that in cardiology soon.
So I want to thank each of you, Judy, Christina, Brian, Ami, and Kevin, for this very rich dialogue. We probably could have spent an hour with each of you independently, but your perspectives are very valuable. At this time, we're going to take a break and return at 10:50. We have a really engaging panel, roundtable physician discussion, so we hope you'll join us then. We'll see you back at 10:50. Thank you.
Produced by the U.S. Department of Health and Human Services.